A Respiratory Case Study by C.C. Neitz. This is our patient, KT. He's a 2-year and 10-month-old male with a chief complaint of cough, fever, and breathing fast. History of present illness for KT. He presents with cough for 5 days with fever. He was seen in the Wolfson's ER on Friday. He was given steroids, Decadron, for croup. He had a chest x-ray which showed negative. He was sent home with a diagnosis of viral syndrome with acute asthma exacerbation. He was supposed to take an additional dose of the Decadron prescribed, and it was to be given today. History of present illness continued. The fevers at home have actually only been for the last 3 days, with a Tmax of 103. He does respond to Tylenol and Motrin. His last dose was at 10 a.m. His breathing is faster, and he looks like he is struggling, per mom. Mother has given albuterol nebulizers a few times a day, but now is out of the medication. He has a decrease in appetite, but he is drinking Powerade. No other family members are ill. He's in daycare, and mother is a teacher. KT's patient history. Today, he is 14.97 kilos. He is up to date on all his childhood immunizations. He is hitting all his developmental milestones. He has no known drug allergies, except he is allergic to strawberries. He gets a rash. His past medical history includes asthma, RSV at 12 months where he was hospitalized, a circumcision in 2018. He lives at home with his mom, dad, one sibling, and a dog. Review of systems. Mother denies any vomiting or diarrhea for the patient. He does appear more tired than normal. He's had a lack of appetite, with a wet-sounding cough, sometimes with mucus. He's breathing harder and faster than normal. There's some nasal congestion. Patient does complain of sore throat sometimes. Mother denies any extremity swelling. Now what? What other questions do we want to ask mom? I'll give you a second to think about it. We want to ask mom about COVID exposure, how long the patient has been breathing this fast, and does he seem more tired than normal? What are the most important vital signs to assess for this patient? That's right, pulse ox and respiratory rate. What tests would you anticipate ordering for this patient? Probably a rapid COVID, flu, RSV, maybe a chest x-ray, and you may need to send this child to the ER based on his presentation. And now for KT's physical exam. We'll start with vital signs. Today we have a temperature of 101.2. His respirations are at 52, heart rate of 148, and his pulse ox is 96% on room air. KT's physical exam continued. KT is smiling and alert. He does appear a little pale, and he's sitting on his mother's lap. There's no tenderness or swelling noted to his head. His eyes are round, non-injected, reactive, with no exudates. The tympanic membranes are pearly gray with good landmarks visualized. He has no crust, sores, or nasal drainage. There is no enlargement to his tonsils. However, the posterior pharynx has mild erythema. He has normal S1-2. No murmurs, gallops, or rubs noted. KT's physical exam continued. On auscultation, KT has tachypnea with subcostal retractions. He has coarse breast downs noted to the right lower lung. The anterior is greater than the posterior. On his skin, there are no cyanosis. He does have good turgor and generalized warmth. He is dry skin. There is no petechia or rash noted. Can you think of some differential diagnosis for KT? I'll give you a second to think about it. These are the ones that I came up with: COVID-19, pneumonia, RSV, or influenza. Did you come up with these too? Is there anything else you can think of that you'd want to order for this kid? Any outpatient tests? Any inpatient labs that we haven't gone over already? You could order a chest x-ray for KT just to see if it is pneumonia or an underlying viral illness or an exacerbation of his asthma. We did decide to do some tests in office. We did a rapid COVID, flu, and RSV, and the results are in. They were all negative. KT's final diagnosis. Let's see if we got the same answer. We diagnosed him with suspected community-acquired pneumonia. We added an additional diagnosis of wheezing. KT's treatment plan. For the wheezing, we prescribed him albuterol, 2.5 milligrams per 3 mLs for nebulization. Inhale 1 vial via nebulizer every 4 to 6 hours is needed for coughing or wheezing. Quantity dispensed 43 milliliter vials. For the coarse breath sounds in the right lower lobe, combined with the fever for 3 days, cough, and tachypnea with suspected pneumonia, KT was prescribed Augmentin ES, 600 milligrams, 42.9 milligrams per 5 mLs oral suspension, 5 mLs BID times 10 days. The treatment plan for KT continued. Take-home instructions. Continue with PO fluids and rest. Motrin and Tylenol for the fever at home. Patient given updated dosing based on his weight today. Follow up in 3 to 4 days for recheck on his breathing, or sooner if patient is still within fever within 48 hours. However, if the patient's breathing gets worse, 60 breaths per minute, stops taking PO fluid, or increased work of breathing, please take KT to the ER. The clinical practice guidelines according to the American Academy of Pediatrics for treating community-acquired pneumonia. They recommend decreasing the use of chest radiographs, blood studies, in pediatric patients with suspected community-acquired pneumonia. We want to rely on the vital signs and physical assessment to aid in diagnosis, especially the pulse oximetry and respiratory rate. We want to prescribe beta-lactam amoxicillin for first-line treatment if the patient has not been on the medication in the last 30 days. The World Health Organization recommends that children ages 2 through 59 months with chest indrawing pneumonia should be treated with oral amoxicillin, at least 40 milligrams per kilo per dose, twice a day for 5 days. As we just learned, the treatment for pneumonia in pediatric patients is amoxicillin. So why did we prescribe Augmentin? Well, last month, KT was diagnosed with an acute otitis media and prescribed amoxicillin. So we don't want to prescribe amoxicillin again. Our next choice would be Augmentin. Thanks for watching this respiratory case study. I hope that you learned something. Here are the references that were used.